practice. This month, the theme is on cornea, and the question that we are discussing is recalcitrant recurrent corneal erosions. What happens next? This is not an uncommon scenario in our daily practice, yet we all deal with it differently according to our discretion and our competence. So that's why we took up this topic to see if there is any consensus or any guideline or any algorithm for practice regarding this. But unfortunately, even the latest of the systematic reviews explicitly states that evidence is not enough to come to a meaningful conclusion. So we are back to square one. So in this 1 hour, nothing is going to happen. No algorithm is going to come out of this discussion. But what is going to emerge is more clarity on the different options available for recurrent corneal erosions and the rationale of when to use what, based on the article or the evidence we are apprising today, as well as the real life practice patterns of the clinical experts who are joining us today. So the article this time is a review article because our research mentor, Dr. Praveen, thinks that it is the most apt for this session. And as always, Dr. Praveen will be very ably guiding us through the research part of this discussion. The review article is from Clinical Ophthalmology by Miller et al. From 2019. And we are really fortunate to have with us really dynamic and leading cornea specialists who are very familiar to KSOS because they are very popular speakers as well. So we have with us Dr. Sujit Naina. He's the chief consultant of cornea, cataract, and anterior segment surgery. And he's also the medical director at Trinity Eye Hospital, Calicut. And we have an equally accomplished Dr. Shaji Hussain. He's the chief cataract, cornea, and refractive surgeon at Abate Eye Hospital, Perinthalmanna. I welcome both of you very warmly to this forum. And both Sujit and Shaji are very active in the KSOS arena too. Sujit Dr. Sujit is our very proactive KGO website, KSOS website editor, and Dr. Shaji is with me on the KGO team. He's the managing editor of KGO. So it is doubly a pleasure to have both of you with me today on this forum. A warm welcome to both Sujit and Shaji. With this, before I pass on to the scientific program, I have this very pleasant responsibility of announcing the quiz winners of our last time myopia quiz. And the winners are in the first position. We have once again Dr. Remya Edasheri. She is the consultant in pediatric ophthalmology, strabismus, and neuroophthalmology at Pioneer Cooperative Hospital. And this is the second time in a row that Remya is coming up first in the KGO quiz, and that brings her into the reckoning for the mega prize that is being planned at the KGO session in Drishti 2025. And in the second position, we have Dr. Jasna Rachel Varghese, cataract surgeon from Amita Eye Care. Congratulations to both the winners, and keep quizzing with KGO. So with that, we pass on to the scientific session proper and get set to deep dive into this review article on recurrent corneal erosions with Dr. Praveen Nirmalan guiding us. Over to you, Dr. Praveen.
Okay, so we'll start with the topic, recurrent corneal erosion, a comprehensive review. This is a review article and authored by Miller, Hassan, Simmons, Stewart, published in Clinical Ophthalmology 2019. Is it 1 minute? Let me just. Yeah, the question of interest was the management of recurrent corneal erosion, what can be done at the general ophthalmology practitioner level, and when should they refer a patient, or the criteria when you want to say that, well, it's beyond my scope and let me now refer this patient for advanced care. Coming to the study, the authors have used a systematic review design. So essentially, it's a comprehensive review that they have done of existing literature. And there are different types of reviews that are possible. You've got something known as a scoping review, you've got a narrative review, you've got a systematic review, you've got a systematic review with a meta-analysis. So different types of reviews are possible. What a review does in its very basic form is to collate, compile, and present the results of multiple studies and that have already been done and published. And then to synthesize that evidence and put it out as a summary of all the evidence that exists. Just by its nature, a review, it's considered to be higher up on the evidence hierarchical scale, but by its very nature, a review has a lot of limitations and pitfalls that are possible. So you have to keep that in mind when you're looking at the evidence that you collect from a review. You don't just say that because it's higher up on the hierarchical scale or on the evidence pyramid that it is acceptable to just use it as it is. We need to think over and look at it in its entirety. And we'll look at some of that later. Coming to the results that have been presented here, and we can see that, well, they talked about the medical treatment. You've got the prophylaxis, the treatment. You've got can it be used as a prophylactic treatment. You've got when it can be used, the indication. And you've got some brand names that are available. I marked the ones in, highlighted the ones in yellow that can be used prophylactically, and ones that cannot be used prophylactically. And this initial, what they consider to be, or the others say, and it's possibly true in clinical practice also, is the first line of management that you prefer when a patient comes to you with recurrent corneal erosions. You've got artificial tears, you've got oral NSAIDs, cycloplegia, antibiotics, nighttime ointments for lubrication, hypertonic sodium chloride, punctal occlusion, soft bandage contact lens, blood serum drops, cryopreserved amniotic membranes, MMP inhibitors, and topical corticosteroids. So you've got a whole list of things there. Some which can be used as prophylaxis, some which cannot be used or not advised to use as prophylaxis. So you've got that there. You've got the surgical treatment also listed, which is when the medical treatment doesn't work as well as you would like it to, or you consider the medical treatment to have failed. You got the indications for the surgical treatments there, and you got anterior stromal puncture, alcohol delamination, epithelial debridement, diamond burr polishing, phototherapeutic keratectomy. They're given the disadvantages, they're given some of the advantages there, they're given a description of what it involves. Now, hopefully you would, I think the paper is being circulated, so hopefully you would have gone through the paper. And I'm not going to walk through the indications in each step. Now, this review has given you two tables and it's given a list. It's probably 15 different types of management strategies that you can use in recurrent corneal erosions. As I said earlier, a systematic review is considered to be higher up on the pyramid of evidence, higher up on that scale. So can you take these results and apply it to your clinical practice from this paper? And that's a question that you need to look at when you say that, well, there is a review, it's a recent one. It's looked at, you've given us 15 odd strategies. So can we take these results and apply it as it is? Which brings us to a question of how do we assess the quality of a systematic review? Now, any systematic review is only as good as the quality of the included studies. The systematic review by itself is not an indicator of high quality evidence. It's only as good as the quality of the included study. So when you are reading a review paper, you need to then go and pick out the individual papers and try to see if those are of a good enough quality to believe that evidence. In most instances, the reporting of the systematic review must include the search strategy that has been used. That's good reporting practice, a search strategy that's been used. What articles, search strategy to identify the articles. What articles were selected? Or what was the filter used to include or exclude studies? And that must be reported. What were the keywords used to identify studies? Once you got that whole list out, which databases did you look at? And then once you got the whole list out, how did you filter through to choose which was included, which was not included? That must be mentioned clearly. And the idea behind that is twofold. One, that you can replicate that same search strategy by using the keywords and see whether you're getting the same list or not. And you can also cross-check and see whether the studies that have come and the filtration strategy that they have reported is appropriate or not. Or is there a bias in that whole process? So one is replication, one is for you also to do it and then check to see if the filtration and the inclusion criteria for the studies that would include in the review is appropriate or not. Has something been missed? Has something been that should have been there been excluded, right? When you're reading the paper, you then need to check, is there a clearly articulated statement or statements about the aims and objectives of the particular review that the authors are doing and the rationale and background. And this is important because we are living in a time when publication matters. Everyone is fond of telling publish or perish and things like that. And publication matters from a career perspective if you are in an academic field. It also matters even if you're not supposedly in a strong academic line, like a professor or something like that. But it matters for your promotion, where you have a set number of papers that you must publish to be considered for promotion. It also matters to put you up in as a visible expert. And so publication matters. Studies take time to do. Studies take effort to do. And so more people are gravitating towards building up the publication base by performing reviews of work that other people did. And you're getting that as an index publication, which you can then show for your career progression. So not all reviews that are coming are actually good reviews. Not all studies that are coming are actually good studies is a well-known fact. Whether we like it or we don't like it, that's a well-known fact. Not all reviews that are coming are also good reviews. So you really need to check out and see if the review, that paper that you are relying on, is actually good or not. So is there a clearly articulated aim and objective? Is there a clearly articulated rationale for this particular review? Is the background clearly mentioned? And are you in alignment with that? Do you agree with that? In the methods, you need a clear articulation of the eligibility criteria for including and excluding studies. I'm not going to take each point and take this paper and say, is it there or not? But I would like you to then go back, if you have not read that paper, to go back and check and see, has this been mentioned in this particular review? Have the authors mentioned the eligibility criteria for the papers that they're included or excluded? Have they mentioned the key questions that they were considering when they started this review, for this particular review? Have they mentioned the analytic framework that they are considering? Have they mentioned the databases, PubMed, Medline, whatever, Scopus, Embase, blah, 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 blah. Databases and other information sources used to identify the relevant studies. Search strategy, especially the mesh words used, the keywords used, so that you can try and replicate it. And the study selection process. So has that been mentioned in this particular review or not? It's something that you need to cross-check in the methods. The data extraction process. How did they take the data out of it? How did they deal with missing data? Did they pool the data? How did they extract information from the included studies? How did they appraise the quality of individual studies? Now, we've got multiple checklists to look at the quality of the individual studies. You've got multiple checklists to look at the quality of the systematic review. You've got the PRISMA framework, you've got the AMSTAR 2 framework, you've got the CAST framework also. For individual studies, you've got the STROBE, you've got the PRISMA, you've got the Equator network. You've got multiple checklists and frameworks available, which you can go through. And then you can check for each item and then look at the paper that you are reading and then see if that's there or it's not there. Right. Now, the reason for this is for you to form an individual judgment. Can I use this evidence that is being presented in this review for translation into clinical practice? Is there an articulation of the summary measures of effect size, the rationale for pooling or not pooling results of included studies, methods of synthesizing the evidence, qualitative or meta-analysis, additional analysis, if it has been done, indicating which were pre-specified, which has been pre-specified before they started the review, which has been done as they have done the review. So how are they working with the data? Again, I'm re-emphasizing this is something that you look at, and I would encourage that you go and try looking at through this paper, whether it's there or it's not there. The whole idea is just because it's there as a table in the review doesn't necessarily mean that you should take it and apply it. You need to form an individual judgment. So pass through this and see it's there, it's mentioned, it's not mentioned, it's mentioned, it's not mentioned. Look at those things there. Have they mentioned how the studies that were included were selected, the list of excluded studies and reasons for their exclusion? Appraisal of individual study qualities, qualitative synthesis, meta-analysis of results, and additional analysis that were done. You're looking for all these things there. Then you want to see a summary of the results for each key question that the review is trying to address. The strengths and limitations that the authors say as that are there as part of this particular review process, the conclusions for each question, gaps, and future directions. So this is a general framework that you use. When you read this paper, presuming that you have read this paper, and if you have not read this paper, read this paper. It gives you a way to work through it rather than just listening and then saying, well, a review was done and one person with a white beard came and said, it's good, it's not good, so it's good, it's not good. That doesn't help you in any particular way, right? So that's why I'm not getting into those details now. I'm giving you a framework to look at it. Look through it, form your own judgments, and then start looking at the evidence and say, well, now I feel that I can translate this into clinical practice. I can take this and translate into clinical practice, or I feel that it's not sufficient else. It's the way you look at evidence in a paper and then take it into clinical practice, right? So question every bit of evidence that you see, question every paper that you see, whoever the author is, whatever the reputation is. Build that way of questioning and go through a systematic framework of looking at the questions, the things that you want to question. Has it been addressed or has it not been addressed? And then decide, okay, now I am comfortable enough saying I can rely on this evidence, or I'm not comfortable enough. That becomes easier as you keep doing it rather than as you keep listening to it. It's a matter of the more you do it, the more easier it becomes. It's not very difficult. Even though there's a lot of jargon that's used to make it sound difficult, it's absolutely not difficult. Something that can be done very easily. It's something that builds up as you keep doing it with habit and experience. So try it out. At least with this paper, you start trying it out. With this particular review, question that you need to think is, have all relevant studies been included? So the question from my side to the audience is, have you, as you read this paper, have you decided that, okay, let me go and do a literature search to see what information is available out there? Have results been pooled? Could they be pooled? In this particular one, there's nothing, not much that indicates that they have pooled the results, right? They have reported on the results of individual studies. Is that right? Is that wrong? Well, maybe if all the studies have got a different design, if all the studies have got a different outcome measure, pooling doesn't really work, right? Unless they're all looking at one particular thing, one particular outcome, and you have multiple studies, and then you can pool. But if you're looking at different outcome measures and looking at different therapeutic interventions, you can't really pool. You can't really pool apples and oranges and try to get a guava as a result, right? Consider the quality of the included studies, which then means this you're looking at intervention. So your ideal design would be an RCT. An RCT may not always be possible, although there's no reason why it need not always be possible for an intervention, but it may not always be possible. The next best design is a cohort study design. So have they mentioned the design of the individual studies? Are they RCTs? Are they cohort studies? Which brings us to the next point, the sample size. Now, all the studies are almost all the studies that are mentioned in this particular review have got a sample size that is small. We're talking about 11 patients, 22 patients, 30 patients, right? So it's almost like a case series with a comparator. Is that sufficient enough? Is that sufficient enough for you to form an opinion that this works or doesn't work? You need to consider the patients that were selected, the outcome measures of the individual studies, the assessments that were done, was there any bias, and the reporting that is done in individual studies. The thing that sticks out for me is the number of patients that straight away sticks out is the number of patients in each individual study. And the question that is that number sufficient enough for you to say that I can take this evidence into clinical practice? Now, is it reasonable to have such a small sample size for these studies? Which brings us to two questions. One, is RCE, recurrent corneal erosion, a common problem? Is it a common clinical problem? If it is a common clinical problem that is being managed, then the small sample size stands up. Why is there not too many studies on that? Is it because it's not important enough? Or is this a serious but rare problem? So it's a problem that must be managed, but it's not so common. Which then again brings us to the question, well then, is it something that can be managed at the general ophthalm level, or should it be entirely at a specialty level? So we get these two things there. One, why do almost all the studies have a small sample size? Is that in any way related to the magnitude of the problem? Is it related to the seriousness attributed to the problem? Is it just that it's not been studied? Other things have been happening. This has not been studied. It's not been reported. We have felt that something works, so we are just moving ahead with that. So that's the thing that you keep in mind. Important question, which I have been telling quite a bit now. Can we extrapolate the results to practice if we have small sample sizes, concerns with the design, non-RCT designs and smaller cohorts? So the review has considered or reports on about more than 15 papers, studies. It tabulates the results. It gives you what can be the medical line of management or first line of management. It tells you the indications for using that. It tells you which can be used prophylactically, which cannot be used as prophylaxis. It then says, well, if it's not working, here's a list of other management strategies that can be used, surgical management strategies. It tells you what's the effectiveness of that, right? It tells you what are the side effects. It tells you that there's an 80% success rate. There is much less recurrence in some. There is glare in some. Don't do in the central axis, do in the peripheral axis only. Some have equivalence in terms of our results, but one is much costlier, one is easier to perform. So you've got all those options up there. But each one reports on very few patients. So is it something that you are willing to take and apply directly into your clinical practice. Now, it brings up what I'm trying to lead subtly to is one of the aspects of a systematic review. One, we look at the evidence and we say, let me use it. An equally important aspect is any review is only as good as the studies that are included in the review. And the review actually points you to gaps that exist in the scientific knowledge. So if RCE is a problem that must be managed well and can be managed at the primary level or at the general ophthalm level as a first line, then, and we see quite a lot of it, then is that a problem that we study to get a better level of evidence from our setting? Most papers on this are old. They're old. It's almost like this was a problem long back and go to hell. We are done with you. We have got better things, more exotic, wonderful things to do. Then at the end, there's a spurt of a few papers coming from 2019, 2022, 2024. Very few papers. So that's my take on this particular review. I'm seeing two things from here that I would like you to take home and reflect on. Is there a problem that must be studied? Can we build, do we need to build better level of evidence? Is this level of evidence sufficient enough for us to say, let's jump in with clinical practice and just do it? Given the fact that most of you, or some of you at least, might be dealing with RCE, would have managed RCE, right? What is your experience with the management of RCE? The numbers that you see, the outcomes that you see, the interventions that you use, and do you see the, do you see the potential for putting out that evidence? What do you do when you see the next corneal erosion, right? Over to the clinicians.
Thank you, Dr. Praveen. Actually, നമ്മളിങ്ങനെ സസ്പെൻസിന്റെ മുൾമുനയിൽ നിർത്തിയിട്ടാണ് ഡോക്ടർ പ്രവീൺ അവസാനിപ്പിച്ചിരിക്കുന്നത്. എനിവേ, we are all as teachers and professors, I am always asking my PGs to go through review articles. And I also go and search review articles first whenever I need a quick recap of what is happening on a particular topic. So it was very enlightening to listen to this particular take on review articles and what all to be the Prisma. The guidelines are not very familiar to all, but it has been made very simple by Dr. Praveen. Thank you so much. And as he rightly pointed out, every study that is given in this paper is only a handful of patients. So I was just looking at the prevalence and incidence of recurrent corneal erosions. I mean, I was Googling it right now, and I have come up with a 23 article, which says that it is 0.96%. That is in the UK. And I don't think that we have sufficient literature from our country. At least I am not aware of it. And I think of all the modules that we have finished, this one was the hardest to find a proper article, as for the reasons that Dr. Praveen mentioned. So we started out to find a consensus guideline from literature, and we ended up identifying a significant research gap in this area of recurrent corneal erosion. So that's what has happened regarding the literature search aspect of it. So I'm sure having a review article in a journal club sort of a discussion in itself is a rarity. And so this has been really nice to listen to you. So thank you once again. And now let's move on to the clinical part of this episode. So let me start by putting a question to Dr. Sujit. Though our topic is recalcitrant recurrent corneal erosions, we have to first identify when they become recalcitrant, or when we say that it is not really responding to our treatment. So the primary line of treatment mentioned in the article and what we all follow is antibiotic and lubricant. So I was just wondering, what would be your choice of antibiotic and lubricant, and how long would you is that the only thing you would do, or in your practice, is there anything further also in that first line management? And how long would you continue? And what will be your endpoints to switch?
First of all, thank you for including me in this uh, talk in this program. Thank you, Praveen sir, for your insights into this, how to approach a review article. Actually, we may not be knowing many of these things. Coming to the question of question asked. See, first of all, if you look at the article, not only this article, if you look at many of the articles in this on this topic, there is no specific definition for this disease. Why? When do you call a recurrent? Is it a second episode? Even a second episode can be called a recurrent erosion. So the definition itself is not clear. Then comes the second part. When do you call it recalcitrant? So there lies the ambiguity. So every clinician, I think, who is dealing with this problem has his own definition and his own method of treating. But obviously, this article, not only this article, many articles on this topic has tried to summarize many points, and most of the articles have tried to give a step ladder pattern. And the first step is obviously a medical management. Nobody suggests a surgical management at the first episode itself. The one reason which I would understand regarding that is recurrent erosion as such can be a presentation of many etiologies. We always think, or most of the times we think it of as a trauma. But if you look at the incidence, the trauma is less than 50% of the etiology of recurrent erosions. So the rest, 20 to 30%, is supposed to be dystrophies, which when you look at the eyes on slit lamp, we may not find any slit lamp findings also. Obviously, some stromal dystrophies or much advanced dystrophies may have some findings. Epithelial basement dystrophies may have some findings, but sometimes we see the cornea is pretty clear that there is no history. Patient never gives a history of trauma, so we don't know what exactly is the cause. And many times the associated risk factors are missed out, which includes the diabetes, nocturnal exposure. The full eyelid closure is not there at night, which leaves the eye dry. In morning, patient wakes up as a painful eye, which is often taken as a recurrent erosion. In this patient, the only treatment you want is a patching of the eye at bedtime, or a lubricant. So coming to the point, the etiology, you must actually you should have some chair time with the patient to understand. If there is trauma, well and good. Then you are directly into the point that trauma is causing this issue. But sometimes if you don't have any clear etiology suggesting why this recurrent erosion is happening, you have to sit with the patient. Maybe you have to see the patient during the acute episode. That is very important. Sometimes the patient may be coming to you after the episode, giving all the history that there was a pain last time and all. The description fits into the recurrent erosion, but it may not be recurrent erosion. So if possible, you ask the patient to come. When you have pain, you please come. You can see the lesion. Otherwise, when you look at the cornea, when you stain the cornea may be absolutely clear. So if it is, even in the conservative management, if you don't take care of the risk factors or the etiological factors, there is no point in treating him, just giving a lubricant or a nighttime. See, the most common thing which we give is a lubricant, and the simplest thing, as you asked, you can give is a CMC or a CMC 1% will be the simplest thing that you can give during the daytime. And at night, you can give him a lubricant ointment, which my favorite, no financial interest, is dexpanthenol ointments. And some brands are giving very good results. especially in diabetic patients. Once you apply, we always say at night time, we have to say, tell them at bedtime. Even if the patient is sleeping at the daytime also, you have to apply one drop. So whenever they go to bed, put one drop and go to bed. Because it's the open, when after the sleep, when you get up, the first opening of the eye is causing this epithelium to get dislodged and cause the symptoms. So always apply it before bedtime. Apart from these two, anything else that you suggest as conservative treatment should have some role in controlling the risk factors also, which may be the diabetes, which may be a meibomian gland dysfunction, which may be, if it is a dystrophy, then that may be taken care of. If it's a dystrophy, then obviously we have to take care of dystrophy surgically or by some procedures at some point of time, sooner, rather than asking the patient to wait for many months. So initial is lubricant with a gel at bedtime. The next step obviously depends on what is that particular patient, what is the cause for recurrent erosion in that particular patient.
I think so. I think that was a very relevant point. Most of us treat the tip of the iceberg, but don't have the time to dig into what lies beyond or underneath the surface. So we need to have some chair time with the patient if it is not due to an obvious trauma. So that's a very important point here. And lubricants, of course, I'm sure that most of us are treating with lubricants. And this question, the other part of this question is now being addressed to Dr. Shaji. What is the antibiotic of choice? Like this is in particularly, would you prefer moxifloxacin or chloramphenicol? Because it is already a compromised cornea, and we would like to have a less corneotoxic antibiotic. So, what is your choice there?
Yeah, my choice would be moxifloxacin for sure. Chloramphenicol, as such, we know that it's a quite a epitheliotoxic agent. So here, the preferred drug would be moxifloxacin for sure. And that can continue for at least 2 weeks until we have a good epithelium that is healed over it. And then we can go in for the prophylactic measurement. Along with that, doxycycline tablets initially helps with regard to the MMP inhibiting activity. Also,
Yeah,
vitamin C.
Vitamin C, yes. So that was the other point. Doxycycline, Dr. Sujit, do you add doxycycline as a primary line of management, or after waiting for some time? Is it okay to add as for primary line, because it is not harmful anyway? So isn't it good to start it off as primary line itself? What do you say about that, Dr. Sujit?
I missed some part of your question actually.
No, the metalloprotein is inhibiting action of doxycycline. So doxycycline could be added as a first line management. What do you think about that?
I normally don't add it as a first line management. I specifically add it when I see a meibomian gland dysfunction as a cause of this. I agree there is MMP9 involvement in the inflammation in the epithelial basement level also. If it is a very severe, as you said, suppose we are terming one particular patient as a recalcitrant recurrent erosion, you may add it as maybe a third step or fourth step. But if there is a significant MGD, then it may be added in the first step itself. I specifically see some cases in with recurrent erosion in cases with acne rosacea. Such patients, when you add this doxycycline or tetracycline compounds, they respond very well. Actually, all the symptoms get controlled. And if you look at this article, there is one specific article comparing the benefits of doxycycline with steroids. I mean, not comparing, as in doxycycline along with steroids they have given. But if you look at it, I think they have given it for 2 months or 3 months continuously.
Yeah,
In
that was the
twice
other
daily
point I
dosage.
wanted to ask. Yeah. How long do you give, Dr.
That is
Shaji?
not a practical.
Maximum would be 2 weeks. That's
2 weeks. 50 milligram BD, what is the dosage in which you give?
100 milligram.
100 milligram. Okay. So fine. So doxycycline does have a role to play. That's the thing that's emerging from this discussion, is that doxycycline does have a role to play, especially in those with meibomian gland disease. So recently I had come across some articles comparing comparing BCL as a second line management versus BCL as a first line management. So what do you think, Dr. Shaji? Do we really need BCL as a first line management?
Here the thing is, make sure there is no source of an infection here. So if we have any plans to place a BCL, make sure we are cleaning and debriding the entire epithelium throughout. If possible, we can just clean it up with a septidine just to prevent any ensure there's no infiltrates. If you are keeping it on an infiltrate, definitely you will have a worsening of the symptoms. I prefer, but if you have debrided a lot of epithelium, it's better to keep a BCL maybe for 3 days and remove it.
Okay. Dr. Sujit, how often do you have to use BCL in your practice?
I use it often, but my practice is slightly different. I may not use it for severe cases. Like if you have a patient presenting with severe cases, large defects, severe lid edema, patient in severe pain, agony, if you put the BCL, patient may not be happy actually. For them, the best treatment would be an antibiotic and lubricant ointment and tight pattern bandage. If possible, continue pattern bandage for 24 to 48 hours. You need not put drops in between at all so that you don't disturb the epithelial growth. But if it is a small defect, patient is slight pain, you can put in a cycloplegic, you can put an antibiotic drop, and you can put in a BCL just to give some relief. It should be taken only as a temporary measure.
Yeah.
It actually builds up confidence in patient that, okay, now I have some relief. It's basically you're doing it to buy some time to discuss with the patient various treatment options.
Yes.
So rather you put it in a severe case, sometimes the patient actually lose confidence in BCL because next time when you put BCL, patient will say, no, last time I had very severe pain after that BCL. I don't want that.
Okay. So better, the points are that better to put the BCL in patients who are comfortable, not in the really acute phase, maybe after 2-3 days when the patient is more comfortable, one thing. And second is better to keep them on a close follow-up and a watch. And how often do you how often do you change the BCL if it is not a healing erosion? You keep the same BCL for, say, 2 weeks or 1 week or say 5 days. When do you decide to change the BCL? Or is it only when there's a debris building up and you feel that it should be changed?
I normally keep it up to 1 month. 1 month, yes. But I do call the patient in between to see whether there are any debris. At 1 month, actually, you can clean it and reuse it if you see that the lens is still smooth. It is not, not damaged. If you want to keep it for more, see, not just for recurrent erosions, we use BCL for multiple conditions, multiple indications. Many indications we keep it for actually 4 to 6 weeks. By that time, you may have to take it and clean it. And the same lens can be used for, twice or thrice after cleaning, up to 3 months or so. There is absolutely no problem up to 3 months. But as you say, if there is a clear-cut epithelial defect and if you put it, you cannot just call the patient after 1 month. You have to call in between and see if it's healing or if there is a infective etiology happening.
Okay. So this question is to Dr. Shaji. What is your opinion of adding on ointments that like hypersol ointment or hypertonic ointments it is mentioned that it is one of the treatments that is effective. So how often do you do it and what is your practice regarding that?
I usually don't use it. I am a fan of dexpanthenol. I see the burning sensation, the discomfort usually causes. So I am not a fan of hypertonic solution. I usually don't use.
Okay, what about Dr. Sujit?
Yeah, it has some role and there is some logic in using it. It is, as per the literature, you are supposed to use it in the maintenance phase, like once it is healed, so that there is, that it takes out the fluid from the epithelium and little more adhesion. But as Dr. Shaji told, I also don't use it much because the patients don't have a good experience with that. So they are not comfortable using it. So rather than that, in the maintenance phase, I use dexpanthenol only.
Okay. So, what about the role of steroids? Because off and on we are hearing about the steroids, but generally, when we have a huge area of epithelial loss, we are sort of cautious in the use of steroids also, especially in diabetic patients and such. So, are there indications for adding on steroids in recurrent corneal erosions? If so, when do you do it, Dr. Sujit?
Clinically, yes, as per the reports, it's again coming back to MMP9 and lipases. There is synergetic action of doxycycline or metalloproteinase inhibitors along with the steroids. As I was mentioning previously, that report, as per that report, they have got very good results. But it's not practical to give a doxycycline tablet twice daily for 2 months. None of them will be tolerating it. So you can give steroids with doxycycline, topical steroids and systemic doxycycline. They have synergistic effect, and you can give it for a short duration in selective cases, in severe cases.
When
Those
would you advise the starting of the steroid? Is it an acute phase or is it after, 1 week or so?
Even in acute phase, if you see that there is no signs of infection, even with BCL, you can give. If you see that there is enough inflammation which is adding more problem to the original problem, there is nothing wrong in adding a antibiotic steroid combination in the acute phase itself.
Okay. What about Dr. Shaji?
Yeah, same here. My initial control of acute phase is usually for 2 weeks, and then BCL is off, and I train the patient like they should be sleeping early. Mobile usage after 9 o'clock should be limited. That's how after 2 weeks it is the normal prophylactic phase kind of starts.
Okay.
Same.
So generally, what is the cocktail that you generally advise in the first week? Is it antibiotic plus lubricant plus steroid plus doxycycline? Okay.
Yeah, that's it.
Right. So after 2 weeks, if it is not if the response is not adequate, that is when you think of other methods. Is that
Yeah.
right?
Yes. Because
So
by then the patient is informed of what, as sir said, we usually give the patient some chair time and we tell them this is the cause. And usually they have this habit of looking at the mobile, sleeping throughout. They go late night with the mobile on, and usually they sleep with a dry eye. That is one primary cause I feel is the reason for that recurrent occlusion that night. Especially if they have taken a long journey. If it's a marriage day, the next day they usually sleep late. These are the usual days when they get an attack. So these days are initially warned, and they should be ensured that they use the prophylactic dexpanthenol on these days.
okay. Dr. Sujit, how long, supposing a corneal erosion is well healing with this primary cocktail of antibiotic and steroid and oxy and everything. So how long would you advise them to continue the ointments, the lubricants, once the corneal erosion is healed?
There are 2 points in your question, actually. If it is a just recurrent erosion, it will definitely heal. There is no doubt that it will remain unhealed. The epithelium is not healing. I can think of only 2 situations where epithelium is not healing. Either it is a masquerade of a viral keratitis, and the patient symptom is not getting, even with BCL and all these routine medicines, it's not getting controlled. It could be a masquerading viral keratitis. Second thing will be a very poorly controlled diabetes, where the epithelium is actually not healing at all. Other than these 2 conditions, most of the conditions, the epithelium will heal with the conservative initial management. So the same mistake a few doctors may be making and most of the patients may be making. Immediately after that, we should not stop medication. We have to continue the daytime lubrication and whatever ointment you are giving for the bedtime for at least 3 months. But patients, if they become asymptomatic for a few weeks or few days, they stop or they forget to use it and they come back with the recurrence. So it's not about non-healing, it's about the recurrence. So recurrence can be prevented in most cases or at least reduced in frequency for if you continue the medicine for 3 months. So I normally ask them to continue at least for 3 months and come back to me after 3 months. Then we will decide whether to continue more or not.
So that is one sort of recurrent corneal erosions where the primary management is now clear. and how long to give a prophylactic ointment, that too we have dealt with. And now let's go on to those erosions where your primary management has not really worked and you are, looking for something more to add. And in the literature and everywhere, they're always talking about autologous serum drops. So how practical is it to actually give autologous serum drops? Are we really practicing it? Are you, any one of you practicing it? What about Dr. Shaji?
I find it really difficult. From my practical point of view, it's difficult. But I believe Sujit sir is
Okay.
able to.
So what about Dr. Sujit?
Yes, I am practicing it. I am practicing it not for recurrent erosion. I've never given it for recurrent erosion. Logically, it may help in recurrent erosion, but for I think that is recurrent erosion is a little smaller disease for which you have to give
Okay.
autologous serum and put the patient into more trouble coming and taking the, preparing and all those things. We have better treatments available, I think. I use it for severe dry eyes, Steven-Johnson syndromes, chronic sequelae Steven-Johnson syndromes. And I often deal with, I work in a multi-specialty hospital where they do a lot of bone marrow transplants. So graft versus host disease, I see a lot. So these indications, I use autologous serum and I've got very good results, not for recurrent erosions.
Okay. So because of the practicality, most of the practitioners may be really, they may not have access to proper preparation and maintenance of autologous serum. So let us skip that. And if not autologous serum, which procedure would you advise as the next step? Because now we are going on to the procedural part or in the intervention, OPD intervention part of recurrent corneal erosions. So anti-stromal punctures have been the mainstay from many decades back itself. So maybe many practitioners are still doing that. What is your experience, Dr. Sujit?
My first line of procedure for recurrent erosion is now diamond bud polishing. And, I've been using it for the last continuously, as first line of therapy for the last 3 years or more. And it has given me excellent results. So I have not thought about initially, I have used few cases of ASP, anterior puncture, and few cases of PTK, but both has its own demerits. Diamond bud polishing, I've got very good results. It's working well in my hands. So that is my first line of procedure for these patients.
All right. What about Dr. Shaji?
Same here. Diamond burr.
Same here. So I think even in the literature, diamond burr is now being noted as a better option than ASP. Only thing is, most of it is specifying some on-axis, off-axis difference, and ASP for the off visual axis ones, and diamond burr for the on visual axis ones is the one that is mentioned in this review article. But mostly, I think most of the practitioners are switching or have already switched to diamond burr. So I just wanted to still there are centers where ASP is also done. So I just wanted to ask you whether Nd:YAG laser anterior stromal punctures are done in practical world, or is it only the traditional anterior stromal needle punctures that are done? Is it because many centers have Nd:YAG and it is a non-invasive method of doing also. So what do you think about that? If they don't have a diamond burr, for example, but they have a Nd:YAG.
In literature, Nd:YAG is told that it can replace or it can be done in place of ASP, but it is definitely never as deep as an ASP. The Nd:YAG is more superficial. There is one friend of mine who is regularly doing Nd:YAG. He says he has got very good results. I have not tried it myself, but if you look at it, those pits which you make are quite superficial. When you look at the ASP, they are saying that you have to actually go in deep into you have to cross the Bowman's layer, then only you can cause the fibrosis. That is why most of the cases, the ASP fails, because when you do, you may not be able to achieve that depth in most cases. You may achieve a uniform depth in Nd:YAG, but that is more superficial than ASP. I don't have a personal experience to compare both. That's my feeling about the procedure.
Okay. So I think both our experts are in consensus that if the primary line of management fails, then the next best procedure is a diamond burr. If you are familiar with the procedure and if you have access, if you have, I think diamond burr is not at all costly, and we can very easily procure one for an institute. And so because that is now the preferred procedure, could you just explain the actuals of the diamond burr polishing too? Like how to do it in very briefly. Maybe Dr. Shaji, can you please explain how you do a diamond burr procedure?
Yeah, it's just a battery operated, like it's like an ink pen. I would say the size of it is very small, and we should aim the location where we know that this is the site of the recurrent epithelial erosion, and there is a constant saline that is being put, or hydration that is being done at the site. We should avoid an excessive burn. It should not be deep enough to cause a scar, and neither too superficial that the treatment is ineffective. So just make sure we are treating and just sliding the diamond burr all around the area where usually we get the recurrent erosion.
Is it an epithelial on procedure or an epithelial off procedure? Do you debride first
we can
and then
we just remove the epithelium. Usually, like at the site, we have to remove the epithelium off, and it comes off usually easily.
and the whole area of the corneal erosion alone is covered, or do you have to go a little into the penumbral area also?
All around the area where we feel the epithelium is weak.
Okay. Are there any tips or any red flags while doing this procedure that the practitioner should be aware of?
The area should be constantly wet, and we should ensure about the haze that might come. So it should not be too deep as well. And just take a GVP from the patient side that they may experience a haze post procedure. Maybe it's not common, but still it's good to inform the patient about it.
So, thank you. Dr. Sujit, what is the post-procedure care that you usually advise your patients following a diamond burr procedure?
Yeah, post procedure, I immediately after procedure, I normally put a bandage contact lens. I maintain it for at least 2 weeks because whatever the epithelium comes, that's also not immediately not a mature epithelium. So give some time to be a mature epithelium and have its anchoring filaments in place. Then I take off the BCL. As long as the BCL is there, I give antibiotic drops and genuinely, frankly speaking, I give antibiotic with steroid, surface steroids, and a lubricant only. Once the BCL is off, I continue lubricants for at least 2 months and Panthenol ointment at bedtime for 1 month. And after the procedure, after 2 months, I stop all medicines and ask them to come back if there is any recurrence or any symptoms.
How frequently do you review them during that initial 1 month of BCL and antibiotic steroid?
No, if I do the procedure today, I will call them on the third day. Then on third day, just to see how they're feeling, if there is any infection or anything, if the epithelium is healing and all. Most of the time, by third day, the epithelium heals. But you maintain the BCL and call them after 2 weeks to remove the BCL. Then tell them the medicine for the next 3 months and call them after 3 months.
Okay.
Unless if
So
there is
that
a
is
symptom in between. Yeah.
okay. So I think now, if even after all this, if the patient is getting recurrent, maybe that is definitely recalcitrant, and then it is time to refer to a cornea specialist probably for a PTK. So that was my next question. So next, when we go to the level next, what is the procedure of choice for you? Is it phototherapeutic keratectomy itself or anything else?
See, yeah, Shaji, you can hear me.
Shaji,
I'll refer to
please.
Sujit, sir.
Okay, so just
So I'm yet to see such a case in the last 3 years.
okay,
Once
fine. Good.
since I've channelized my recurrent erosion management with burr polishing and as the points we already mentioned, But if it comes, that clearly shows that there is something I'm missing from the etiology point of view. Something, and most probably it may be two conditions again. One, diabetic patients. All diabetic patients, I tell them. Trauma patients, I tell them confidently, I'm giving you a 99% assurance that it will be healed. But diabetic patients, I tell them that there is a possibility that it may come back again and you may have to undergo the procedure. And before going into PTK again, if you have got a good period of remission after the first burr polishing, like maybe 1.5 years patient didn't have any problem, and then after that it starts, you can try burr polishing again. There's nothing wrong in it. You can
Okay.
repeat
How
it.
much after the first one can you try the next?
There is no definite recommendation regarding that, but I think, see, why I told 1.5 years means that shows that the initial procedure has worked for them. So that is an indication that, okay, you can go ahead and do it once again, and maybe it will work again. But PTK is, of course, PTK is one thing which you can offer. If you look at the literature, the recurrence rate after PTK is more than the recurrence
More
rate.
than the burr polishing. Even in this article, it is mentioned that it is more than the burr polishing.
And it is, in my experience, it has happened. PTK, after the PTK, patients have come back with recurrences. And at that time, I was not practicing burr polishing. So I had to offer them another PTK. But definitely now, if that patient comes again, I will be offering them burr polishing.
Okay.
They can do
So
3 diamond burrs at the cost of 1 PTK.
yeah. So I think the message is loud and clear that diamond burr is the in thing now, and it is accessible to most ophthalmologists. And the procedure and the regimen, everything Dr. Sujit has explained so well, and it works very well in the hands of both these experts. So diamond burr, it's high time that for recalcitrant recurrent corneal erosions, at least in our part of the country, diamond burr is a very viable option for all of us. And our referrals to the cornea specialist can also probably come down because diamond burr is a technique everybody can do. And as Dr. Shaji rightly mentioned, it is economic compared to PTK. It's an OP procedure compared to the operation or the operation theater experience that the patient has to undergo anyway for the other procedures. So, PTK and certain other procedures. So, on the whole, diamond burr seems to be the star right now on the recurrent corneal erosion scene. And we are slightly overshooting time by 4 minutes now. So maybe it's time to conclude this session. It has been a really, really very nice session for me personally because we are seeing recurrent corneal erosions. Not that infrequently. I don't know how much the incidence is, but not that infrequently. And most of them don't need procedures other than, 90% of them do very well. It's my experience, I'm saying 90% of them do very well with the initial medical management itself. You have required the diamond burr and anti-stromal punctures. We have tried. I used to do that once, twice, thrice I have done, but it did not work in my hands. So I stopped doing those procedures. So still, diamond burr is here to stay, is what we feel. And so recurrent corneal erosions, the conclude, it is something that the takeaways are, one is, no, don't just keep treating the tip of the iceberg if you feel that it is recalcitrant. You have to go into what is causing the problem and address that as well. And secondly, you have, though we don't have a perfect algorithm, we have a good cocktail that our clinical experts have told us in the primary setting itself. We can start off with moxifloxacin, a lubricant like dexpanthenol, and lubricant drops like CMC. And you can add tetracyclines, especially if it is having a patient is having a meibomian gland disease also, plus steroids even in the acute phase. If you are using BCL, you have to keep the patient under frequent follow-up, and the BCL can be continued for 4 to 6 weeks. So that is and as of the second line of management, now diamond burr has replaced all the other procedures as the top preference for both our clinical experts, as well as that is what the evidence is also pointing to. So this is what this 1 hour of discussion has come up with, and I'm sure that this will definitely help you answer the question that Dr. Praveen Nirmalan had put up at the end of the article. The next time you see a recurrent corneal erosion, what will you be actually practicing? So that is up to you to decide. And we are ready to call it a day now with these inputs, and I hope it has been useful to you. Thank you so much, Dr. Sujit and Dr. Shaji and Dr. Praveen for making this 1 hour worthwhile. Thank you.
Thank you.
Thank you.
Before I go, let me just remind that a quiz will be now live on the KSOS website based on this module. And please do take it. It will be live right after this episode. It's a self-assessment quiz. Will also help you to revise and learn these points once again. Thank you.